I see some, we're recording in progress. And I'd like to let you know that this is the 9th year of the Neighborhood Health Series. And typically we take a little bit of a break in the summer and we come back in the fall. And so what you have in front of you is a flyer with the remaining lectures for this year. And we have 2025 is now all planned out. And so we'll have that for you coming up soon in the next flyer. But we're so grateful to have you here tonight. And we're also very excited to welcome our friends on Zoom. We are Zooming with our South Jordan campus in Utah, as well as some other folks that have joined us by Zoom that are out in the universe somewhere else that's not Utah and not Nevada. So this is a really nice opportunity for us to get this information, which is very important to a lot of us, to more people by doing Zoom and allowing our Utah folks to be a part of what we're doing. And so, as I mentioned, we're recording. And so we will post this to the NHS page on the roseman.edu website. So if anybody wants to get that information that they didn't get today, it was too fast, or look up past lectures, you're welcome to do that. And we are going to hold questions till the end, if that's okay. And everyone saw the restrooms. If you could silence your phone, would be very grateful for that. So again, we are so excited to extend this to South Jordan. And real quick, before we get started, I would like to introduce someone very special. This is Craig Fraley from the Clark County Credit Union. He is our sponsor. He's been our sponsor for a long time. And without him, without CCCU, we wouldn't be able to do what we're doing here today. So I'm going to give him a quick moment.
Thank you. Thank you, Vanessa. Good evening, everybody. Thank you. Thank you very much. We are the Medical Field Credit Union, and we are very proud to sponsor Roseman's Neighborhood Health Series every month. We absolutely love this. Some of you have heard me say this before, but if you have an allergic reaction to big banks, we are the cure. And we are owned by our members. We were established in 1951. We are not for profit. We're owned by our membership. It's a great place to bank. There's some magazines right over here that highlight a lot of the information. Don't wait for the movie to come out. It's a really good read. And also, to be a member, you have to put $5 in a savings account, and that stays in the account the entire time you're a member. But if you use that code, which is the code 5, when you join, we'll put that $5 in for you. So you don't have to do that yourself. All right, everybody, have a wonderful evening and enjoy the presentation.
Thank you, Craig. Well, great. Well, tonight we're here to talk about Alzheimer's. And a few of you, when you walked in, I was asking you about your interest in this specific topic. I know a lot of us are interested. And so I personally have a strong interest in it and have learned a lot about this disease in the past 10 years. And so I'm really, really excited to hear from our speaker tonight and very grateful for him to be here with us. I also wanted to let you know, some of you have been coming for many years to this event and we've gotten to know one another. I just wanted to let you know, I have a very special guest here tonight, and that is my mom, who's right here in the front row. That's Barbara. So thank you for welcoming her. That means a lot to me. Okay, well, I would like to introduce our very, very special presenter, Steve Embley. Dr. Embley is a board-certified family medicine physician and fellow of the American Academy of Family Physicians. He has 3 roles here at Roseman College of Medicine. He's the chair of the Clinical Sciences Department, director of clinical skills, and the medical director for Roseman Medical Group. His extensive experience in medical leadership and education includes his previous role as Assistant Dean of Clinical Sciences at Nordic College of Osteopathic Medicine, where he spearheaded the development and implementation of their pre-clerkship clinical curriculum. Dr. Embley's career is marked by a deep commitment to patient care. He has practiced in a wide range of clinical settings, including family medicine clinics, hospitals, urgent care centers, and rural medicine, where he provided comprehensive care encompassing obstetrics, emergency medicine, and hospital medicine. His leadership roles have included serving as hospital chief of staff, hospice director, and chief medical officer of a large multi-specialty group. Prior to his medical career, Dr. Embley earned an MBA and spent many years in business development. Dr. Embley and his wife Heidi are the proud parents of 5 adult children and recently welcomed their 10th grandchild. Passionate about serving his community, Dr. Embley actively participates in volunteer healthcare and local organizations. As a medical educator, he emphasizes the importance of listening to patients and instills in his students the values of integrity and compassion as cornerstones of exceptional medical practice. Please join me in welcoming Dr. Embley.
Wow, that was very nice. Way too nice. As with most everyone, all of those things that she read just means that I'm not as young as I wish I was, right? And I think that's how we all get as we move along in life. And yet it's kind of fun to remember. And yeah, I'm bringing up maybe remembering on purpose because we're going to talk about Alzheimer's tonight. And remembering, of course, can be one of those things that's a struggle and something that is, I know, very personal to a lot of people. Before I get started, I want to just openly acknowledge with a lot of love and friendship, there's another name listed besides mine on this slide. It's Dr. Greg Schneider, who recently ran into some family issues and had to leave us and go back where he has a better support system in Florida. But he created a lot of this material. He was a beloved coworker of mine, and I miss him already. He literally just left this week. And so it feels very fresh, but he was putting together the basis of this and then sort of turned it over to me. And I want to wholly acknowledge his contribution, not only to this presentation, but to my life, just as a little aside for that. Well, let's get going here. If I could get the arrows to work. There we go. Oh, yes. Thank you again. Craig's not here, but I'm sure grateful that they're here so that y'all got dinner. And just be aware, they're not sponsoring me per se. So what I'm telling you is very as bias-free as I can make it be, because I know we all have biases. I'll talk a little bit about why perhaps in this topic that I feel like I have some bias, because like you, I have some very dear loved ones. And of course, as you can imagine, a whole bunch of patients that suffer from this and the associated issues that come up. For me, this statement, it's like if you're not seeing something about Alzheimer's in the news, you're not following the news. And unfortunately, if you click on a few buttons nowadays, a few times and read a few Alzheimer's articles, then you're probably getting flooded in whatever your stream of media is, whether that's something like a social media or whether it's even Google News. Like it'll, of course, cater it all to what you think is important. And unfortunately, when those systems curate news for you, you're getting a whole bunch of really good stuff and a whole bunch of really, really bad misinformation, and unfortunately, sometimes disinformation, meaning intentional bad. Most of the time, it's not that, but that certainly exists, and it exists a ton in Alzheimer's disease. We have a whole bunch of diseases in the world that we don't really know how to cure, and we really struggle to even control very well. And Alzheimer's, unfortunately, is one of those, and anytime you get that, that's a perfect place for people really to be fed a bunch of misinformation and disinformation. So my hope tonight, I don't pretend that I have some secret sauce here, because the reality of it is for things like Alzheimer's disease, there is no secret sauce. There's not some hidden thing out there. There is something that I hope someday we discover. But the reality of it is when we get those kinds of things, there's probably multiple things that are, I'll say, causing, and we'll talk about a few of those today that we're really aware of, but yet we know that's not the whole reason. So we'll talk about that a little bit today. So you're going to see a lot in the news. And what my grandfather might say is, I don't know if is there a way, Cameron, to turn off that side if I just pinch it? Oh, there we go. Thank you. What my grandfather might say is it turns out that the article I saw yesterday and today are actually the same. And while that's partly maybe a little bit of a jab at Alzheimer's just for the fun of it, it really isn't, because things get respun over and over and over today. I could pull up, I'm sure, a newspaper article over the last few weeks about whatever newspaper or news outlet, it doesn't matter, and I could read some story about Alzheimer's, and if I did a search for it, I'd probably find the exact same version of the story that was 5 years ago, that was 10 years ago, that was 15 years ago. It gets sort of respun and it gets sent out there. Oh, there's this new cure. And there are some things we're going to talk about today that I'm just excited and I hope help. But this is one of those diseases that is really, really hard because we don't have a pill. We don't have a shot. We have things that can help, but nothing that will cure. My own grandparents, when I sort of personalize this, and I bet if I were to walk up to any one of you here in person or online, everybody's touched by this. Everybody. And if you're not, you just haven't asked anybody around the Thanksgiving dinner table, right? Because it's sort of everywhere. When I think of my own life, my father's still alive, and my wife's mother and father, so 3 of the 4 of I guess my sets of current parents 2 of those living folks have Alzheimer's. If I go back 1 generation from them, and they have long since passed, but I think 3 of the 8 had Alzheimer's. Now, if you ask, what do they have in common? Well, okay, there's probably some similar bloodlines once you know, my wife's side or my side, and hopefully there's not a lot of commonality between those 2 sides, but they were aging. That's what we're going to talk about tonight. The depressing part of this is the leading cause of Alzheimer's is living. It's breathing longer than the person next to you because you got older. Now, that doesn't mean, however, that age causes Alzheimer's, because we have evidence of millions of people who live very old and never get Alzheimer's. So it's one of those fun things that the leading cause of it, you actually want to get older. But then if you get older, you might get Alzheimer's, but you might not. So we hope that we can identify other factors, and we do have other factors, and we'll talk about those tonight. I would love it if I could hand the mic around. If I was with a small group of medical students right now, I'd run over to these 4 little people, and I would just kind of just, how many people do you know? And how many people do you know? Because the truth is, if you're asking around, it's a whole bunch of people. And the people that come in my office, and common question, hey, can you see my fill in the blank, father, mother, uncle, whatever. I think they might have a memory problem. But can you not tell them? And so it's another problem we have with Alzheimer's is we're a little bit afraid to talk about it. We don't even like to talk about it with each other. And so hopefully tonight you'll give me permission to just talk openly about it. At the end, I'm more than happy to answer questions. I'm not the type of person that's going to pretend that I have every answer. I have some great resources to look things up. It's one of the joys of being a doctor. But at the same time, the truth is I know I can look up and look up and look up, and there's some of the things I don't know how to answer because there aren't really good answers for this. Tears families apart. I wish it doesn't need to. That's a part I think we truly can work on as a human race. For today's session, kind of if you look at those bullets there, we're going to talk about an overview of Alzheimer's disease. I'm also going to mention the other types of dementia. Alzheimer's disease is just one of the, I guess, flavors of dementia. We'll talk about the diagnosis and evaluation, some ways to management, and then everybody's hoping for these new treatments on the horizon where I share with you the secrets of the future and how not to get Alzheimer's, and don't sit on the edge of your seat, enjoy your sandwich. That we're not going to talk too much about that, and then some question and answers. As we go through this, I'm sort of going to use this Mr. A as the case as we go through. Now, we do this with medical students all the time as we try to bring it into a little bit of a real world. This is, a case, and we try to use real world cases of people that we've seen or that we know, and we try to depersonalize it so you can't figure out maybe who Mr. A really is. But let's say that Mr. A shows up to his family physician at the age of 68, which is not an arbitrary age. It's a really common age for people to finally say, or maybe in this case, it's this person's wife, could bring him in and say, I need to be evaluated. It's very frustrating because as we've gotten better nutritionally and medicines and maybe taking care of ourselves, boy, there's a whole bunch of people now that are totally physically doing great at 68. And this is a hard conversation to come and have with someone. Says he has no particular concerns, but his wife has urged him to visit the doctor for evaluation of what she noticed as difficulties with verbal communication over the past 4 years. So this isn't a brand new thing, but finally someone in his life got up, maybe the courage, or maybe there's other things, who knows why, she didn't ask before, but over the past 4 years, she says, in particular, the wife says that he seemed to have difficulties finding words during speech, frequently used the wrong words, and had trouble remembering names. When I talk to patients like this, like Mr. A, and I ask him questions, guess who answers? Because they're just used to it. It's not even offensive to Mr. A or to Mrs. A. That's just the way they've learned to function. And sometimes we say, oh, they know each other so well, they're filling in the blanks. I mean, that is partly true. They've probably been together a long time and they can fill in the blanks. But the reality of it is they've just adjusted their whole life pattern of communication because Mr. A struggles to find the words and has been for quite a while. When questioned, Mr. A admitted to some of these problems, which he probably hated doing, and he estimated that the problems maybe had been going on for 10 years. Super common pattern that we see in the office quite a bit. And as I say, as we go along with this presentation, we'll hear this. So these are some of the questions that maybe you're asking yourself. I don't know. Certainly things we would ask medical students. We give them a little snippet of the case. And then we say, okay, what are you worried about? Where would you turn for information? Where would you go to do an online search? Now, because of the size of the audience, I'm not going to take the time to go through individual answers, but I hope that there's some places that you can turn to. Now, certainly I hope, like you can't even believe, that every one of you have this amazing primary care physician that you can go and talk to. And yet I know the truth is that that doesn't always exist for everyone, and for a whole bunch of reasons. I mean, it's really expensive, or insurance issues, or you don't live by one, or you just don't know anybody, or the last 5 of them you tried were terrible to you, or the office staff made it impossible to get an appointment, or the reality of some of us are just private and I want to search online. I want to look at home and I want to see what's going on. When you do that line, when you search at home, what we've listed here is just a few places that as a family doc, you can trust these places for the most part. Now, I say for the most part because there's nowhere with perfect information. But here's places that are way better than Facebook, way better than Twitter, way better than your local gathering around whatever restaurant or bar or whatever, even better than Thanksgiving dinner table. The hard part about these sites, though, and I just want to be open about this, is you're not going to get as strong a testimonial from people, because they're going to tell you things like, we're not sure, and this might be real, whereas the people, unfortunately, in our lives or online will act very sure. And they will say, I know someone that was cured from Alzheimer's because they went and got blankety blank infusion. And it sounds so convincing, and they knew somebody. And we'll talk about some of those things today. Unfortunately, they don't exist. I wish they did. But please know there are places to go to get real information. I, of course, really like thefamilydoctor.org because I'm a family doctor. It is absolutely sponsored by the American Academy of Family Physicians, but it's for patients. That's not a place that I necessarily go search for information, but people like me create that information. And so I do have a little bit of a trust in it. But whether it's Mayo Health or even Clark County Library, there's some great stuff that's there. All right, dementias, including Alzheimer's disease. So this is kind of a big picture overview of dementias. Dementia is this category that in medicine has those following bullets, where someone has progressive intellectual decline. Nobody ever loves to hear that. It's one of the important things diagnostically is it's not due to another disease or a mental disease. That's so, so important. When you go to a doctor with Alzheimer's disease, and we'll talk about some of the testing that would happen if you were to go be tested for, but you're mainly testing to make sure it's not something else. Because there are a lot of things that mimic Alzheimer's disease. That's why I like to encourage people, please, if you think that's something going on in your life or someone you love, get an evaluation, because sometimes you can find out. I'll use a really sort of harsh example, but one that I've lived so many times as a doctor, I can't even tell you, of people coming in, I'm sure my dad has Alzheimer's. Can you just, I need to bring him in so you can take the car keys away, which is a yucky part of my job. And they bring him in and you kind of hear the story like, okay, I'd like to do the following tests. And they're like, no, I don't want any testing done. Please, let's just do, I know, well, they're expensive and you just something seems off a little bit. You do a test and maybe you find out there's a little bit of a brain tumor, but it's an operable one. And they can get it out. And this person can be returned to function. We don't find it that often, but it does happen. Or you find out that they have a vitamin B12 deficiency and you can fix it literally in that case with a pill or with some infusion. So there are things that are fixable. Unfortunately, they're not when it's Alzheimer's. And then the other key takeaway there is we talked about at the start that age is the main risk factor. And we'll talk about other risk factors today, but age is unfortunately in this disease way more important than family history and way more important than the number of times you got knocked out when you were a kid playing football. It's way more important than whether you even smoked and things like that. And those are all important, but they don't even touch just aging and how our brains deal with that. That kind of the bulleted thing in there in the middle, dementia is a progressive decline in intellectual function that is severe enough to impair social or occupational functioning. If someone comes to my office and they're having memory issues, but it's not enough to impair them in any kind of a significant way, then we call it that bottom bullet that I underlined. We call it mild cognitive impairment. And that just means it's sort of, we don't call it Alzheimer's, so nobody gets mad, but it's just a mild cognitive impairment because we're trying to be, nice. But that just means there's some memory issues, but not severe enough to matter. And I say that lightly because I know some people in my life that this affects. And unfortunately, they don't want to hear that there's nothing to do to stop the progression. This is really, it's an awful phase to be in, but it's reality. Here's more focused, instead of just dementias in general, here's Alzheimer's disease. Typically, this begins after the age of 60. Doesn't always, but literally we're talking more than 80% of those that get dementia, Alzheimer's dementia, it happens after the age of 60. 65 to 74 years old, 5% of the people in that age group have Alzheimer's disease. That's a lot of people because we have millions and millions and millions of people around in this country, and then we have billions around the world. So it's not a tiny number when something says 5%, but it's not most people. Of 75 to 84-year-olds, 13% of people in this age group have Alzheimer's. And if you're over 85 or one of your loved ones, 1/3 of the people in that age group have Alzheimer's disease. Now, I want to recognize those are horrid numbers, but I didn't say 2/3 of the people had Alzheimer's disease in that age group. It's only 1/3. But again, if you think of my situation with my parents and my wife's parents right now, they're all in their 80s, and it's 2 out of 3. So we're a little bit unlucky, I guess, because 1 out of 3 is the average. So that's kind of the numbers. We wish we could change that trend. Unfortunately, I actually think this is fortunate. Our life expectancies are continuing to go up. It's absolutely a miracle. We have a little bit of a blip with COVID, but we're on our way back up again. And unfortunately, that does mean we're going to have more people around us with Alzheimer's because we don't know how to stop that trend. By 2060, 15 million people in the US will have Alzheimer's. And this isn't because it's spreading in the water. This is because the population is aging. And we have that whole wonderful baby boomer thing, and it's just all coming, and we're all getting older. And I love it that I'm getting older. It's better than the alternative, I suppose. But aside from age, there are some other risk factors, and we'll talk about those a little bit. They include family history. It's probably the most common question that I get in the office from somebody that's 35, and they'll say, I can't remember where I put my keys very often, and I forget, am I getting Alzheimer's? And yes, it is part of a family history, but it's not like a given. If you have, I have my dad and my wife's dad, it doesn't mean my kids are going to get Alzheimer's. It doesn't mean I am. It doesn't mean I'm not. It's just a risk factor. Diabetes is a risk factor for Alzheimer's. Cigarette smoking is at least one of them that's on that list. You can't change your age, but you can change if you smoke or not. So it is at least a factor that you can control. Now, I use that word carefully because I know control is a strong statement. It is very, very addictive, and I've worked with a lot of people through the years that try their best to try to quit smoking. If that's an issue that you're worried about, if you're worried about Alzheimer's and you are smoking, please get some help because it'll help you in a lot of ways. High blood pressure is something that somewhat is controllable. There's certainly medications for that. Obesity, I guess you could say, is somewhat controllable. That's a tough one again. You probably ought to get help with from others. A history of significant head injury. Well, that's one that I can't control anymore. As a young boy, I thought it was really cool that I got to play all those sports. But I was one of those kids that, got knocked out a few times. And so you sit and wonder, is that going to affect me? Hasn't so far, at least not that I remember. So anyway. Physical activity and social engagement does appear. Now, anytime you hear a doctor say things like, it appears, that means that the data isn't 100% conclusive, but it sort of leads you to believe that being physically active and socially active. So that means having conversations, that means interacting with others in person and that sort of thing can be protective. The recent studies, I wish, said that doing Sudoku and puzzles, like everybody wants to think, that's one I see commonly online all the time, is that'll protect you from Alzheimer's. Those studies haven't turned out so well so far. Not that they cause it to get Alzheimer's, but it isn't protective. But social interaction, talking with your neighbor, your friend, your family, really can provide some help, and physical activity certainly helps. But that's true with everything in the body. So I don't think those are exactly earth-shaking. I mean, nobody's probably surprised by those things, that those can be helpful. Dementia is distinct from what we would call delirium and psychotic disease in medicine. Delirium often occurs, let's say that I end up in the hospital this afternoon for something, and they give me some medicines that cause me to act out funny. That's more delirium. I mean, that's an easy way to think of that. If somebody has other diseases, let's say they're diabetic and their blood sugar is way too high, and when that happens, they act funny and don't remember things well, that's not dementia, that's delirium, because it's caused by something else. So that's kind of how we look at that. And then there's certainly mental illness. This can mimic Alzheimer's disease a ton. The one place that I almost feel like I can cure dementia, and I said earlier you can't, because it's not really dementia, but I will have people come in that are absolutely clinically depressed. They may have been that way for years, like somebody like Mr. A, who came in and he said, yeah, I've been feeling this for 10 years, and his wife's noticed for 4 years. And when you really dig into it and treat their depression, their Alzheimer's, quote unquote, goes away. Because it really was just depression. It was masking something that made it seem like that. So that's, again, another maybe sort of plug to say, if you think this is a problem for you or someone, please try to get some help, because there are some things that can mimic this. I wish it always helped. I would love to go be able to cure my dad of Alzheimer's by helping with his depression, but it doesn't happen. So let's get back to Mr. A. Let me give you a little more history as we kind of work our way through the evening here. His only changes in Mr. A's activity of daily living or his social function, so he's only had mild changes. He still handles the household finances without noticeable problems. I suppose I should have underlined the word noticeable, because maybe there are and they just don't know. And hopefully that's a big concern that truthfully will kind of bring people in when people notice that the money gets mismanaged or something like that. He performs well-learned chores well. I want you to kind of focus on that word well-learned chores, because Alzheimer's, typically people, if they've done something their whole life, they can still do it. It's sometimes we refer to it as muscle memory. That might not be the greatest phrase, but you're still able to do those things for the most part in the early stages of the disease. That kind of lasts with you. If you don't forget how to drive a car, you might not remember where you're going, but you don't forget how to do it. And that's why it's so frustrating to take away the keys of those wonderful people. The wife reports that he increasingly asked for instructions. He dressed himself, ate himself, and performed the usual self-care tasks. He's able to shave and do toileting. One of the common things that people will come in for is, hey, I noticed that mom or dad or whatever, they've left the stove on twice after they've cooked. Because they're really good at cooking, but you just can't remember those short-term important tasks sometimes. So those are some early signs to kind of think of as they're going through it. And Mr. A is obviously suffering from some of those. He continues to work in his longtime profession as an engineer, which is also something that's very frustrating for people because they feel very capable of working early on. Although he admits he has had experiencing some mild difficulties at his job. For example, he complained that he couldn't understand the logic of what some people said to him. If you really dig into it, and you do when you're evaluating someone for these diseases, you find out that things like he sees his writing as slower and messier. We call this dysgraphia, but it's a really super common with Alzheimer's to start having writing issues. The brain's just not functioning, even when you're really trying hard, you just can't get yourself to write like you really want to. Now I want to differentiate, just because I'm bringing that up for a second. Arthritis can obviously cause writing issues, but doesn't mean you have Alzheimer's, okay? That just doesn't. If it's mechanical problems with the hand, that's a little bit different than the brain just isn't able to compute that. Friends had not noticed any changes in behavior, still was able to socialize, and that's fantastic. Mrs. A had noticed some changes in his driving. Historically, he was an excellent navigator, but now seemed much less confident. Now, if you're like me, there's a few of these things that I've mentioned, whether it be handwriting or less confident driving, that you're going, oh, I've noticed that. So that's another hard thing about Alzheimer's, is most of us experience some of these things as a normal part of life, right? You have just more inputs coming in all the time, so you're not as comfortable, you're in a new place. So I don't want anybody to run out, because we have this trouble with medical students all the time. Nobody has more sicknesses than a second-year medical student, because they're just learning about all the symptoms. And so they'll run up to you thinking they have every one of them, because we all have pieces of them. Or if you're like me, you almost get upset if you're watching, say, a television program or something, and they come on and there's this ad for some new drug. And like, well, if you've ever been sad, like, really? Or if you've ever needed more energy, like, yeah. So again, I'm not trying to set up scare tactic or anything like that, but these are just some of the symptoms that very commonly present in an office setting. When Mr. A is questioned about his own memory, in retrospect, looking backwards, meaning he and his wife both noted some changes in his ability to remember the content of recent conversations. So in other words, I could have a conversation with Mr. A, or let's put a name on there, my father. I can talk with him about when I was a young child. And just like me, he doesn't remember every detail perfectly. But if I try to ask him what we talked about 5 minutes ago, it's nothing. He's going to ask me the same questions that we already talked about 7 times. Yeah, my kids are still okay. They were a few minutes ago, and they just had a new grandbaby. Did you guys hear that part in my intro, by the way? Last Wednesday, it was great. I hit double figures. I had 10 grandkids. Whoever thought? Like, it happens. It's kind of the most exciting thing ever, though. So they live in San Antonio. I get to see them in a couple weeks. So I'm all excited. That middle bullet there, Mrs. A mentioned that he had become somewhat more repetition and tended to dwell on past events. I mean, can you see the sort of the logic of that, though? If your memory doesn't remember really recent events, that you start to dwell on things in the past. And it almost feels like words that we don't love to use. It almost feels like they're becoming obsessive about things in the past. And it's because partly there's not a lot of current that's really processing in their brain. There's an area of the brain, we're going to talk about areas of the brain called the hippocampus, that sort of turns a current activity into a memory. And when that's broke, you can't get a current activity to turn into a memory, but you still have your old memories that are out there. So at least those are there, and they're wonderful. And unfortunately, as the disease progresses, as those even become inaccessible. He does seem somewhat more irritable than he used to be, and he expressed less interest in new things and activities. Otherwise, his personality seemed relatively unchanged. Now, I wanted to stop briefly here for a moment because I know a lot of you have Alzheimer's in your life and in your loved ones. And I know that some of you have not experienced this. You've experienced agitation and even anger and meanness. This disease is a big spectrum, because over here is Alzheimer's and is very mild and is maybe like we're talking about with Mr. A right now. And then unfortunately, part of it is it just progresses. And I hope for you and your loved ones that's slow, but sometimes it's really fast. And it can get through phases that are just angry and mean. I was actually telling Cam earlier tonight, sitting over here before we talked, my father, who has Alzheimer's, is in this beautiful stage. He's happier than he ever has been. He's just a happier person right now, and doesn't upset at anybody, and nothing makes me mad. And this is really cool, and I know it won't stay that way forever. But I'm really grateful for when that happens. But I hope I remember this phase when he gets to that next one where he hates everything we're doing and doesn't remember us and those sorts of things. So, because that's part of things. So I just want to acknowledge as we're going through this that some of you are probably going through harder times with loved ones and this disease. When I look at Mr. A's medical history, and I'm doing this for the purpose of talking about some of these things that maybe you hear rumors cause Alzheimer's or whatnot. So that's part of why we chose Mr. A. He suffered from high blood pressure. 10 years earlier, he'd undergone a foot operation and a procedure for stomach reflux. Medications that he was currently taking were medicines for blood pressure and stomach ulcers, and he also needed a sleeping pill. None of those things that I just put on there caused his Alzheimer's. But the studies sort of show that if he wasn't taking his blood pressure medicine and had blood pressure that was really high, that Alzheimer's may have come on quicker in his case. So that just another reason to try to control things. Again, it's not cause and effect, but you can elevate risk factors. Social history, this person completed college, so education of 16 years, whatever that means. I try to think how many years I went through school. I don't know, 16 years sounds okay, not too bad. He was employed as an engineer. He had no recent history for several decades of either alcohol or tobacco use. And again, you come to a setting like this and you're probably going to think, well, I don't want to hear about tobacco over and over, but as a doctor, if you want to do one thing to change the world, let's try to stop smoking. It'll just do wonders for your health. Even if you've been doing it a long time, even stopping now would be fantastic. And it's hard to do, I get it. His family history. Mr. A's mother died at 67 in a nursing home. Unfortunately, as doctors, that's a lot of times all the information you get, but you have to wonder, what was that all about? And of course, a lot of times people don't know. She did suffer from dementia, type unknown. Typically in doctor land, meaning what I interpret from that is back when she was in a nursing home, nobody wanted to use the word Alzheimer's. A lot of people used to call it old timers. And in fact, if I go and tell my mother-in-law and her husband has dementia, if I go and say things like, his Alzheimer's is getting worse, she gets angry at me. But if I say his dementia is getting worse, she totally will listen to that. So the word Alzheimer's can really upset people because of some past history. So his father died at age 79 of a heart attack. Mr. A had 2 older siblings, age 71 and 73, with no known mental disorders. So again, we would be asking students, what do you think? What do you think's going on? Now, as a family doc, I've heard a lot of information now, and a lot of it lines up with maybe some Alzheimer's disease. But guess what? I've got a list in my mind that is probably 10 to 20 things long of what might be causing it. And my job with Alzheimer's disease is to go make sure this person isn't suffering from the other 10 or 20 things, because those are potentially fixable. And so this is where we get into a lot of discussion with people and family about waste in medicine. This is one of those places that doctors order unnecessary tests, because if those tests turn out to be normal, then you could say to me rightly, they were unnecessary. And of course, I would look back and say, but if they turn out to find something, you're going to be grateful. And that's a thing that we have to weigh and figure out as a society. That is a very, very tricky part of our human existence, to try to figure out when is it appropriate to do a bunch of testing. Now, what you'll hear me sort of advocate for tonight is a little bit of a middle ground. I do think there should be testing done, but I don't think every kind of test should be run, because then you start to get into some really speculative stuff that is really expensive. The way that I measure this, and you'll hear this as we go through the rest of the presentation, is I like to check for things that I could fix, or that I could at least make a difference helping. I don't know what value it does anything for me to do some special fancy scan that nobody's ever heard of before and be able to tell you, hey, you have a P732 deletion, and there's still nothing we can do about it. So, but that's just a personal thing, and hopefully I do a decent job talking to patients and letting them make the decision. Here's a little chart that shows you Alzheimer's disease versus some of the other dementias, because there are others. The reason we even differentiate here is not just academic, although I love talking about those sorts of things, and research is a fun thing, but we treat these a little bit differently. Now, as I mentioned before, we're not talking about, I didn't say we cure these differently, but we do treat them differently, meaning we use some different medications or some different approaches or some different heads up for the families, depending on what's causing things. One of the easy ones to talk about is the second one down there, vascular dementia. This is typically caused by people having series of what most commonly gets referred to as mini strokes or TIAs. And so you end up having an Alzheimer's-like condition that is caused essentially from a cardiovascular disease. That is, you're having strokes all the time. And we do have some things that can help, I'll say, prevent that. Controlling blood pressure and controlling cholesterol, and sometimes even needing things like blood thinners, or reevaluating people's hearts for things like valvular issues, and a lot of those kinds of things potentially can be causing and mimicking Alzheimer's disease. And so there's some things there that we want to differentiate, because the treatments for that are very different. Sometimes you'll hear about this thing like with Lewy bodies or frontotemporal dementia, And not a lot of people have these, but when they do, they show up a little bit different. That one at the very bottom, you see, comes on to people in their 50s. So if somebody walks in there and they're maybe younger, in their early 50s or something, I'm thinking a lot more about that one just as a cause of what's going on for them. And if we were really doing a medical student stuff tonight, I would now shut this off and give you a test about it. Because everybody's got that table memorized. Just kidding. We don't even do that to medical students anymore. Those were just, I'll be old for a minute. Those were the good old days. Like, when we had to do that. Patients, families, and providers should be aware that a patient's insight into their own cognitive change may be very vague or completely absent. The worst thing that can happen to me as a doctor when somebody comes for this evaluation is to be dropped off and just put in the room and everybody wants to wait in the waiting room or in the parking lot. You need the input from everyone around. You really do. I'll liken it in a totally different way to just, if you were evaluating a child for ADHD and the parent just came and dropped the kid off and said, go ahead, see what they're like. Oh, can I talk to the teacher? Can I talk to the parent? Nope, just decide. So when you're doing Alzheimer's evaluation, it's so important to have family or friends or coworkers. The person themselves is really not the greatest source because a lot of things they're not going to notice. Having said that, there is great difficulty when I ask somebody else in the room, no, for real, can you tell me about them having memory problems? And you see people like gulp and they want to be respectful to their parent or their spouse or their loved one and they don't want to answer that question. So it is tricky and I acknowledge that sometimes it can be. There's different areas of the brain that get affected. And that's sometimes you get asked a million questions. Well, are you having trouble with short-term memory loss? Are you having trouble finding words? Are you having trouble, making decisions? Is there just tiredness? Is there learning some learned behaviors? And that whole list there is just places in the brain that can be affected. And then we look for different kinds of diseases and different things. So some of those questions that you're asked might seem like they're sort of like redundant over and over again. But it really is trying to help the doctor and or the family to help narrow things down so that we can get a better sense of what's going on. For those that are probably more familiar with me, we probably have some people that are neurology kind of science people out there. You probably know the brain a lot better than I do. Was my favorite part of anatomy. The first time I got to touch a brain, like just blew my mind. Like I couldn't believe it. And I still want to honor and to be grateful for that person, for me, who was willing to donate their body so that I could learn medicine. But when you get to the brain, all those little squishy places actually have different functions. Now, I went through medicine actually as a second career. This actually kind of surprised me, and I'd heard my whole life, oh, you're right-brained, oh, you're left-brained, oh, you're this, that, and the other. But to me, it's just one blobby mess of things that somehow communicated, and I don't know how it worked. And to find out with specificity, different areas literally control. So if you imagine, I told you earlier, well, it turns out a couple of those patients have had a tumor in parts of a brain. And so if I were to pick, let's say that frontal lobe that you see on the screen up there, that big pink part, and it says under there that problem solving or speaking is one of those things that happens there. So somebody can come in and say, they're hardly speaking at all. And we joint decision and decided to do that scan and found something right there pressing on that, and they take that out. It's like magic. And really, the rest of the brain wasn't affected. But if you hurt one certain part of the brain, that becomes an issue. Now, right in the middle, you see that kind of a squirrely orange thing that, I don't know, sort of curves towards the front. That's called the hippocampus. And that is like this master thing that turns information into a memory. And that is something that there's a lot of parts of the brain that get affected with Alzheimer's, but that's one of those that people, like I say, notice early because you stop creating new, fresh memories. So it's deep in the brain. It's not something that you can go just, well, let's go give that a shot or a pill or cut it out or anything like that. It's really close to what we call the brain stem, which, for people that are biologists and whatnot and whatnot, it's right near the brainstem. It's like the core of you as far as a physical body, needing for breathing and that kind of thing. So this is a really important area. Was that a fun interlude? You got to study your anatomy for a minute? All right. Some other signs and symptoms of Alzheimer's disease. This is things that can help families as well as the physician, but timing and time course of onset of symptoms can be very, very helpful. One of the things that we try to ask people, and you've heard me bring it up with Mr. A here, is I wanted to know when things started. And you sort of push that pretty hard because this is something that if it's really there, it's probably been sort of happening for a while. And it's hard to notice those symptoms because sometimes they're vague, but when people look back, they're typically able to say, okay, yeah, I sort of had trouble finding words for a while. Or, yeah, it became more than just losing car keys. It became, you just can't remember what somebody told you 2 seconds ago on a regular basis, started 5 years ago. It is important for people to know and be able to review their medical history. So I jumped right to the one I wanted to talk about. When I say medical history, there are some medicines that can cause memory problems. And they are very common medicines, but they don't cause it very often. So they're commonly used. Certainly, we would never give people something that we thought in most people cause memory issues. But there are, for instance, some things that treat chronic diseases, diabetes or Parkinson's or whatever, that can cause some memory issues in a few people. So it's crazy important. If you run off to some specialist, this is one of the reasons that I love being a family doc, because I usually know what medicine someone is on. But if you go to a doctor and ask them to evaluate you for something like Alzheimer's, they need to know the medicines you're on. You can't like just assume that somehow that you're able to separate that, because sometimes it literally is as simple as taking someone off a medicine or replacing it with a different type to help them. A functional history. So this would be like understanding their daily lives. Are they still able to brush their teeth, comb their hair, take a shower, get in the car? Those sorts of things become a very important part of this evaluation. A physical exam, once in a while, will identify some other hidden illnesses and things. Sometimes we can even find some skin lesions that will give us a hint that there might be something different going on. Doesn't happen very often, but once in a while. And then certainly a complete neurologic exam can help identify the part of the brain that's affected. The thing that people probably, it's been in the news a lot the last 4 years, because, and I'm certainly not going to bring up any political anything, but we hear all the time that people are giving people assessments to assess their cognitive ability, right? And if you heard these tests, you'd kind of laugh because, yeah, they're not much as far as testing, but it's one of the best things we have. I put the example up there of this clock drawing. Really, really, really super common one that we use in the office. You literally hand someone a piece of paper and ask them for whatever time. In this example, we would say, draw 10 minutes after 11. Now, if we were to give that to a 16-year-old today, they couldn't do it at all, right? They couldn't draw clock face. They'd have to write 10:50 or whatever. Like, they couldn't even do it. But you and I know how to read a clock face. And it's something that should be there in our memory. But as our memory starts to go, and some people say, is there anything I can do at home? And not that I wouldn't want you to go do this all the time, because this doesn't help you avoid dementia. But if you did this with your spouse or your loved one to kind of look and see what happens, it's not that hard to tell whether they knew this or not. And they genuinely, sometimes they'll get frustrated because they don't know how to do it. But more often than not in the early stages, they'll just do it wrong. Like really wrong. So it'll put 4:30 on there, or they won't even know how to put the numbers on the clock face. And it'll surprise you. It's like, what? You don't know where the 2 goes on a clock? But it happens, and it becomes very real. And so this is some of that executive functioning, but this is one that we use pretty often. For those of you that are here with me, like there's the normal one is on the left, and then you can see variations of what gets drawn all the time. And one suggestion, if you do this with a loved one and they fail, maybe don't make a big deal about it to them. They get really mad when they fail, because this just is something we all think we know. And again, don't try with a teenager because they have no clue. They're literally like, well, you have to pull your phone out to do that, right? Yeah, or something. You've maybe heard of that top test that's listed there, the mini mental status exam. It's called the Folstein one. It's actually trademarked, and now, unfortunately, we have to pay somebody money to use it. It's just a series of questions, but it's things like, I'll sit down with a person literally face to face, and we'll have this little sheet in front of us. I'll say, hey, we're gonna do this evaluation. Great. Can you tell me your name? I mean, it starts out very simple, and then you're doing things like, can you spell world backwards? Now, none of us go around spelling words backwards. And if you do, that you have a great kind of fun. I don't know, maybe a love for puzzles and word searches or something, but it's not that easy to go, D-L-R-O-W. But if you really stop and try to do it, you can do it. Now, do you have to be really careful that the person doesn't say back, well, I've never learned to read, and so I don't know how to spell. That's a different issue. We use different kinds of tests. Or we'll say things like, I'd like you to count backwards from 100 by sevens. I asked my wife this the other day, crazy intelligent woman. She's like, oh, I can't do that. Because that's what everybody's response is. But you say, no, just go slow. Just start for me. 100, 93, well, 86, 79. Really, we can do it for those that have been through what I'll say is a kind of a standard school system in the US. So educational level does matter. But if you start to do those tests, they seem really complicated at first. But then if you really do it, everybody gets 100% on these tests. The only one that people sometimes miss is at the start of the thing, I'll say, yes, ma'am, I'm gonna give you 3 words: apple, bee, and cauliflower. And I'm gonna want you to remember that in 10 minutes. That seems impossible. Okay, just repeat it to me, and they'll say back, apple, bee, and cauliflower. Okay, can you remember what those 3 words are right now? Apple, bee, and cauliflower. And then I'll leave that and come back and ask them those same 3 things. And for the most part, everybody gets them. When they don't, everybody's really embarrassed, and that's fine. Usually that's the only thing they ever miss. So there's just little questions like that. And then we used to say, maybe this is more funny in a political season for you, but we used to say, who's the president of the United States? But now that gets people angry. It doesn't matter what side they're on. They either tell me how there's a problem, or there should be a problem, or there will be a problem, or there won't be a problem. And so I usually don't say that anymore. I say things like, what city are we in? And what state are we in? And things like that to sort of replace, because then nobody gets angry about it. So just those few things that maybe have changed through the years. Don't ask anybody about politics. It's not the best way to make a friend as a doctor. There are other tests I have listed up there, formal neuropsychiatric testing. That would be sort of the gold standard. It takes several hours. It probably takes you 6 months to get in somewhere to do it for the most part. So we don't use that very often. It's not something that I hardly ever, for what I'll say basic Alzheimer's disease, ever send somebody for that testing, because very few insurances cover it. It takes a long time to get into, and the information that comes back is, oh yeah, they have memory issues. You're like, really? We do a lot of imaging with this, and I put up 3 kinds here. When I first trained in medicine, it was simply a CT scan. A CT scan, for those that are, and there's probably people in this audience way smarter than me about this, but a CT scan shows wonderful things in a static image. It shows things like bones. It kind of shows you where there's not bones or some empty spaces. And it shows you things like tumors. And so that's what we did. We would scan somebody's head because we were basically just looking for that. A few years into when I started to practice, we started to use MRIs. They became a little bit more affordable. Before that, it would have just been somebody, that had a lot of money, I suppose. But then MRIs sort of became the standard. And MRIs do give us more information. The MRI, these wonderful radiologists can actually look and see, oh, you're having more atrophy in the brain. And we're going to talk about that in a little bit. And that gives you more hints that somebody may be suffering from Alzheimer's. Now, I wish that that meant somebody was or wasn't. But unfortunately, I can scan people of completely normal health, and they will also have brain atrophy. That just happens as we age. And so it's not diagnostic. None of these scans come back with an answer of Alzheimer's. But they might see something, and we'll talk about a little bit in a minute. They might say, hey, there's some demyelination going on. And those are some things that you can start to see. The PET scan has started to come into more and more and more of a favor. And it's being used more and more, not just for Alzheimer's, but a lot of different things. And so if you ever go with a loved one or whatever, it's totally a fair question to say, well, why are you choosing that scan instead of the other one? If I were to list those in order, they are actually listed in order. A CAT scan is probably dirt cheap, and MRIs, for the most part, has become less expensive. They're still quite expensive, and PET scans are still a little bit more rare. They're all fairly safe. They're not anything that's going to kill somebody. So if people have the access to them, at a minimum, if I were encouraging someone, I would want them to get an MRI if they were really concerned about this, because it does give you some helpful information. We do a bunch of labs. Here's where some of the let me be very kind in how I say this, if I can be. Here's how some of the pseudo providers out there get a lot of money out of people by telling them they need, I don't know, thousands and thousands of dollars and a million different types of lab work. But there are some that really matter. And there's great evidence, for instance, around testing vitamin B12. There's great evidence around doing just some simple thyroid tests. I get people mad at me because I run a syphilis test. But syphilis can remain dormant for years and years and even decades. And yet its only manifestation is it's destroying the brain. And it's treatable. So if I find out somebody has it, I can fix it. So yes, I test for it, even though I get a bunch of old people that get really mad at me. Why are you testing syphilis on me? And I'm like, I don't know, I'm sorry. HIV tests are something that we can now treat wonderfully. Complete blood counts to look for just simple things like anemia and whatnot that can mimic this. Blood glucose levels. I can't even count the number of people that come in for memory problems and they walk out of the office diagnosed as a diabetic. Lipid panels, those are just to look at cardiovascular kind of things. There are other testing that can be done. These tests, I put them in a different category because they are very, very expensive. There's not as much utility, but these are the ones that are the ones you're reading about in the newspaper. Because somebody just sort of, and I don't want to say these were just found and invented because it's now a decade or two, but in medicine, that's not very advanced. But you can do some genetic testing for things like ApoE. That's one that I love to see in newspapers because none of us knows what it means, but it sure sounds fun. And so the journalists, for some reason, like to print ApoE. You can do a spinal fluid evaluation. So yeah, it's getting a spinal tap and looking for things like amyloid or tau proteins. Those can be very important. And in certain variations, when we can't figure out and we're not sure what's happening, do order those once in a while. If you went straight to a neurologist and if you went and said, I want everything tested, you're for sure going to get those things done. But that's sort of because you set the stage by saying, I want everything. So sometimes you get what you ask for. And I'm all for that because sometimes that'll help people. And if people are in a position financially to be able to pull that off, but I also acknowledge that there's a whole bunch of people that really probably couldn't have that done because they're going to choose whether to feed their family or not for the next year or get a test run. The neurologic evaluation is very important. And it can go all the way through, but let's talk about for Mr. A. He clearly had some mild difficulties in concentration and attention, even from the things that we talked about today. He was unable in his test to spell his 5-letter word backward. It is so frustrating to people. He gets difficulty repeating a complicated sentence. Those are things that we do in that mini mental status exam. His language from an observer standpoint, and I don't think his spouse would have ever used this, but his language was abnormal. He frequently, when he spoke instead of his wife, he used the wrong words when answering questions. For instance, and these are common ones, people mix up things like house and mouse. They'll say pretzel instead of bagel or something like that. One of the other parts of the test is we will show them pictures, and sometimes people have difficulty naming objects. And again, it's not smart or dumb. This is just parts of the brain that look at a picture and they'll know what it is. But the part that connects to turning that into a word is the part that's affected. And so they just can't say. You show them a picture of an apple and they'll be staring at, yeah, I love those. I really like to eat those. What is it? I love those. It's red. But they can't get themselves to say apple, which is too bad. And the one that that Dr. Schneider put here, I actually really like it because they'll be talking about something they love like tennis, but all they can get themselves to say is like they're hitting the ball. You know, and that's how they'll describe the game of tennis to you. So anyway, those are some things that you would notice in someone like Mr. A. He certainly was disoriented. They couldn't name the address. And some people say, well, that's not a fair question. It's true. I don't always know the address that I'm at. So we try to say some things, but most people can do date, and time, which is nice. Memory testing did show some significant impairments. He was unable to remember the several objects shown to him. He was unable to remember items of general knowledge, such as the name of recent presidents of the United States or other things. He was unable to do multiple subtractions or sum up several numbers. I hope you're seeing a picture here that it's really clear after doing those tests. This isn't like a wonder if he has memory problems. This is clear memory problems. But yet it's something the family has lived with for at least 4 years and probably longer. On Mr. A, there was lab and X-ray and other testing that were done. His testing from his blood tests all came back as normal, which it normally does. They elected to do a research project and try to get the cerebral spinal fluid examination. So he went and got a spinal tap. It was normal. And other things on a chest X-ray, they saw he had the hiatal hernia, which we already knew from the history. They did an EKG, which showed that everything was normal. So essentially, this person's lab work was normal. They also did the additional testing, an EEG, which is something that looks at brain waves, which you would think, well, that would show Alzheimer's for sure, and it doesn't always. But it was done, and it just showed slowness, which is non-diagnostic. And then an MRI was done and showed that the brain structure was very normal. And so sometimes you say, well, why don't they always get one? Because it just doesn't, sometimes it doesn't matter. And that needs to be a trade-off that somebody makes a decision of. This person did get sent for neuropsychological testing, which is partly why he was chosen for this case, so that we had it here. And they came back with this incredible diagnosis of moderate impairment of memory. And the family was like, we already knew that. Yes, you did. But it clearly identified things that were nice, because it talked about he had difficulty specifically naming objects, repeating words. So we kind of knew the area of the brain that was affected. He performed poorly when compared to reading and writing tasks and his arithmetic abilities. And again, this person was an engineer. They should have probably been really good at this and really struggled with it. And he was relatively unimpaired with things like abstract reasoning and visual and drawing. His clock probably would have been normal. So at this point in the story, we again would gather together the medical students and go through, okay, now what? Are we finally to the point where we can get to a diagnosis? Because you certainly shouldn't have been there after they just walked in the room. It takes a long time to get there. And so Alzheimer's disease is the diagnosis for this person. There are some things, and people tend not to listen to these, but since I'm sure again that some of you are suffering with this in your family or loved ones, those two that the bold one at the top, that's non-pharmacologic approaches, these things are two of the things that actually matter. They can really help. Aerobic exercise for 30 minutes. And notice I didn't say cure. And I know aerobic exercise means something very different for a 16-year-old than it does for a 56-year-old, than it does for a 76-year-old, than it does for somebody that's in a wheelchair. But the fact is, the more you can move, the better, or have somebody help move. Movement helps. Maintaining an active role, and what this is really referring to is having some social interaction with human beings. Do a whole bunch of us worry about what's happening with the social networking of the world and the isolation that's going on? Yes. I'm worried that will affect memory down the road. I hope not. There's also the idea that there's still interaction, but without that face-to-face interaction, some of these studies would suggest, who knows. What doesn't seem to help, and we keep trying it over and over and over and over and over, is memory drills. My family members force my family members that have Alzheimer's to practice memory drills. They just do. I can't stop them. I've tried. They seem very painful, but people are convinced you just need to practice. Your memory will get better. Computerized cognitive training. Vitamin E, put down here, deserves discussion. It doesn't seem to help prevent Alzheimer's in those that are already with mild cognitive impairment, meaning if the memory problem has already started, this probably doesn't help. But there seems to be a little bit of improvement in functional decline with those that are already at Alzheimer's. So it's not necessarily preventative as far as stopping to get to Alzheimer's, but maybe once you get there, it helps a tiny bit. But I hope you're hearing it in my voice. I'm using a lot of maybes and possiblies, and it might be one of those things you're like, well, is there a downside? Well, yeah, if you take too much of anything, it's a downside. You can kill your kidneys with too much of any vitamin. So you don't just want to pour it on, but it's also really cheap, and maybe it's okay if you're having a little bit of problem and you want to stop decline. Stop, I shouldn't say stop. Let's get into some medicines, because this is where most physicians end up actually going, but I want to tell the reality, and hopefully any physician that you talk to would say these same things. There are these medicines that we call cholinesterase inhibitors. It's the most common one. It goes by a brand name of Aricept. The generic name of it is donepezil. And they are sort of first line for somebody with, well, I'll say regular Alzheimer's disease. I have a note there that they don't help frontotemporal dementia. And it's interesting when I have the discussion with families about starting this, like, well, are you sure they have Alzheimer's? Yes. Are you 100% sure? No. And they ask the same question every time, and I hate this question. What can you do to be 100% sure before you start anything? And here's the unfortunate thing that medical students learn, because it's real right now. And I hope I'm not crossing the line for anybody that's too sensitive. The only way to 100% diagnose this is through autopsy. That's the 100% diagnosis. So you can't do it on a living person. Thank heavens, and let's not try. Let's find another way. If there's blood markers, there's a whole bunch of people doing studies. This is one area that does get a lot of funding, so hopefully somebody will figure something out that is more exact. But starting these medicines when somebody's having early Alzheimer's can slow the progression of it. It's hard for me sometimes to understand when families just say no, because you can't prove to me, so I'm not going to do this. And the reality is there's side effects of medicine. So yeah, if somebody takes it, they're allergic to it, or it causes too much dry mouth or GI stuff, I mean, of course we would stop. But for a lot of people, it slows progression. And that is absolutely just a gift to a lot of families to be able to slow the progression of Alzheimer's. So again, I don't think they're magical. They don't work if it's frontotemporal dementia. But again, we try to differentiate that other ways like age and that type of thing. Once you get a little more severe, most physicians tend to put on another medicine. The brand name is Namenda. And that can help with moderate to severe. And again, I put help there. All it does is slow the process a little bit, and it's not very much. So if it's a huge expense, that's another issue. Most of these medicines have been around long enough that they're not expensive anymore until I get to that next bullet, because it's newer medicines. And the one you see there, and it's funny, of course, as a physician that maybe learned a little while ago, I know it's a new medicine when I can't even hardly pronounce the names. These are wonderful kinds of things, though, because there are medicines for a lot of diseases now that are out there that really can make a huge difference. I mean, just a huge difference for people. And a lot of them are in these different categories of what we call things like biologics and that kind of thing. And they just work in different ways. And this is one of those. But unfortunately, the studies so far are very little clinical benefit at a very huge cost. And if you read those things together, that typically means no one's covering it. And there's not a whole lot of benefit that's proven yet anyway, but I still have hope for medicines like this. And this is just one example of them. They actually are investigating new areas that are ways to fix some of these things that are happening in the process of the brain, to untangle some of the things we call tangles, or to try to help the demyelination process, or to try to help, but they're at a more what I would call a DNA, a genetic kind of a level. And so we're just not really good at this yet. And so if you're of the type of risk taker, when I'm talking to families, that you're willing to sort of, and it's not huge risk, I don't want to pretend it is. These have been through studies enough to know that you're probably not just poisoning someone outright, but we also don't know they help very much. And whenever you're talking about doing something, but these are the ones that are in the newspaper all the time. Somebody discovered a new cure, and it's usually this kind of stuff. And if you go and really read about it, you find out that they're really expensive and they have very little clinical benefit, at least that we've figured out at this point. And again, I hope one of those turns into some magic, wonderful thing. Let's talk about some of the other things that go with Alzheimer's. No one likes having Alzheimer's, even if they don't know it because their memory is so bad. They're probably going to suffer from things like depression, insomnia, and agitation. There are ways to help with those. The medicines that are available for those still, I'll use the word work in Alzheimer's. They don't cure the Alzheimer's, but it might help somebody not be so depressed. They don't cure the agitation, but it might calm things down so it's not a violent outbreak. So there's some ways to control some of the symptoms that are crazy important for family members and caregivers. Alzheimer's disease, when it advances, and I'm sure I'm talking to several people that are living this, the caregiver has the burden. And it's hard. Please do not feel like you're being weak. If you have an appropriate medicine, now I'm going to use that word on purpose because there can be some inappropriate things, but appropriate medicines for things like agitation or to help with moods is not a sign of weakness of the caregiver. It's a real thing to help. Please take advantage of those things. And yeah, make sure you're talking to somebody that's competent. So you're not just, we're not saying you should just drug somebody up. I'm not suggesting that whatsoever. But there are some simple ways to help. There's medicines, if you read that little bullet about depression, for instance, there's no that medicines we know we should avoid. So this isn't just like willy-nilly throwing something at it. These things have been studied, and we know what makes Alzheimer's worse or better. And so there's some things we would use and wouldn't use. A common thing for insomnia that really doesn't do well with geriatric patients, which is typically what we're talking about is Alzheimer's, is something as simple as Benadryl. That is not a good solution for sleep for someone with Alzheimer's. So again, I know it's inexpensive and it's available, but those kind of medicines do mess with a lot of other things in the geriatric population. So it's not something that I would recommend. I put trazodone here not because that's like my favorite or something. It's a very cheap. It's been around forever, but it's something that is well tolerated. For agitation, we typically now start with behavioral techniques. Thank heavens. In the olden days when I first trained, we would essentially drug people up. We start with behavioral techniques, and if you get people involved that are good at this, they can really, really help and teach you how to deal with something that is getting kind of explosive. There are some medicines that are available, but they're kind of a last resort for things like agitation. All right, so Mr. A was technically diagnosed with Alzheimer's disease. We finally convinced the family to not be mad about it for that. The examination showed that his memory was severely impaired, is no consistent, he displayed prominent language problems, and there was no evidence of other issues, which is sort of what, if you were reading a doctor's note, the Alzheimer's diagnosis typically always ends with, and we couldn't find anything else wrong, because that's what you're trying to do with all the studies, is see if you can find something else to explain the symptoms. Let's talk about follow-up, and I do this somewhat hesitantly because I don't want to be discouraging. It's not like every person that goes through Alzheimer's goes through these steps. It's not like they're done in a certain order. It's not like they're done at a specific time frame, but there are patterns that we can obviously see following people. So this is Mr. A. The patient did try some research studies, which I think is awesome and totally commendable for people to try those things, as long as there's not too much of a burden. Nonetheless, his cognitive abilities continued to decline. His thinking and his memory worsened. Over the 2 years that we followed after his presentation, his modified mini mental status exam, where we asked about spelling world backward and all those sorts of things, he was scoring a 37. It went to a 23. I know that that doesn't mean anything to you, but that's bad. To go from that big of a change shows that there's problems happening. His performance on a word generation task, which is some things that sometimes we do, dropped from the 10th percentile, which is where he was diagnosed, to the 1st percentile. And for his education, you would have expected him to be above the 50th percentile. Conversation became increasingly difficult for him, both in making himself understood and in understanding others. He felt like he had ups and downs. That's how he would describe his days. That's how my father's describing his days right now. Some days are good, some days are bad, and that's great. And on some days, though, the symptoms were more pronounced than others. At this point, as a physician, you're trying to pay as much attention to the caregiver. I'm not going to say more, but you're trying to pay as much attention to the caregiver as you are to the person, because this is really hard as a caregiver. At about 2 and 3 years after that presentation, he became literally just confused. Posture changed. Some things that people really notice in advanced Alzheimer's disease. And I know this is hard to talk about. My apologies for those that if you're struggling hearing some of these things. Started to have falls. It kind of looked like Parkinsonism. And it's not like you can't have Parkinsonism and Alzheimer's, but reality is advanced Alzheimer's starts to look like what we think of when you think of Parkinson's. He began to lose control over his urination, which is things that people hate. Women can relate to that more than men. Men, for some reason, think that's the worst thing to ever happen. At years 3 to 4, he became increasingly suffered from agitation and did require hospitalization, really just for outbursts because he was agitated. He was prescribed some antipsychotic drugs, which is not the first thing we want to do, but it did help him for a little while, and it was great. He could no longer follow any instructions and expressly verbal he wasn't able to express himself verbally in any way. He became completely disoriented to both place and time. And I'm picturing someone in my mind right now, again, one of those grandparents that I talked about. This is how I knew them as a little boy. This is what I thought Alzheimer's was people that didn't know my name. They were mean. And that's just not a fair thing to think about people. It's great to try as a caregiver to reflect on those good years, but it's really hard when you're in the middle of it. I want to acknowledge that. At year 5, he fell and broke his hip, apparently from an unwitnessed fall. He had a total hip operation, which, if you're out there wondering, well, why did they, I don't know. They chose to have a total hip operation, but he never did walk again. He developed a fever, and within a month, passed. Now, I'm not trying to make this be a downer. I'm trying to allow you to see Mr. A's course because it went for several years. He had noticed symptoms 15 years before this. And probably 13 of those years were, I'll do it a bit more realistic, maybe 11 of those years were fantastic, still did great, and didn't have a decline until those last few years. But those last few years are very, very hard. We should all wrap our arms around people that are taking care of folks that are suffering with this. There are new horizons out there and things that we might be able to treat this a little bit. So I don't want to leave this on a downside, because one of the things that's cool about Alzheimer's is compared to some of the other things that we deal with as a society, this one does get a lot of funding. Maybe it's because we're all so scared of this. I haven't met a family member who has somebody, my grandpa had it. Everybody is totally panicked that if they forgot anything, am I getting Alzheimer's because I don't want to be like my grandpa or grandma? There are new things out there on the horizon. Plaques are a big problem in the brain. And so there's a lot of things that are out there. There's 3 medicines listed up on there that maybe have some modest beneficial effects. If you were reading the news, a couple of years ago, oh my word, in 2021, when that top one there got approved, of course, my world, but just exploded with news reports and everybody came in. I hear there's a cure, and unfortunately there isn't, but they are expensive. They require intensive monitoring, but they have had some great results. Of course, any new medicines also include some downsides. There's people taking aim at preventing destruction of the brain. And so there's a couple things like cancer drugs that we're trying to repurpose and are being studied for these things. There's ways to block production of things that cause plaques. There's always more drugs being considered. So I don't want to leave with no hope, because what I've witnessed in medicine over the past few decades is amazing breakthroughs, of course, when you least expect it, because of some amazing researcher that's doing something. And so I hope we're all willing to support those type of efforts. But I also don't want to leave with a reality. There is no secret sauce for this right now. One of the other things is there's this tau protein. And if you can keep that from tingling, there's the thought that that will help. And it would help if we can figure that out. There's people looking at reducing inflammation. They're researching things like insulin resistance, which is growing like crazy. And so trying to see if that has an effect. There's people studying the heart-brain connection. There's hormonal therapies. I listed a couple of these specifically because there's also some pseudo therapies out there, meaning ones that don't work, that people are trying to take your money, that are targeting these. These are not developed yet. There certainly can be help. If you eat better, if your metabolism is better, that absolutely helps. So please eat nutritiously. Please exercise. I mean, those aren't things you came here to hear tonight, but those are the reality of the best things that we know sometimes. Let's look at a couple of brain slides. I'm not going to bore you with a lot of these, but the little inset there, the brain should be squishy together. There shouldn't be spaces. So this is a brain. You can see that there's the little carve outs or the sections, instead of being all just squished together, they look like canyons. They really shouldn't look like canyons in the brain. That was an autopsy picture. Is it amyloid plaques? And again, whatever, these are mostly for students, but these are important things that if they're studying. But again, what we're looking at, again, is slides and pictures of an autopsy. So that's how you would really see these kind of things. Those little areas that are lighting up are problems. You see amyloid plaques. You also see tangles and whatnot that are there. Those are some of the things. So this is a PET scan type of an image that you can see. So there are some cool things that you can get. Here's more of the autopsy results. You see these tangles. And that's where I'm going to take you. There are some references. I don't have tons of time. And I don't want to leave you on a down note. There are new horizons. There's our good things. I hope the message you really heard was, please, if you have someone that's doing this, please know that you're loved for taking care of them. But please get help. This isn't something you need to tackle alone. And hopefully there's resources around you. But thank you for your time.
Thank you, Dr. Embley. Okay, we have a few minutes for a few
I'd be
questions.
happy to answer if there's
Yeah,
some questions.
any
real
questions,
quick.
but I'm going to hand you the mic so that we can make sure that you're heard on the
Awesome.
recording.
Mhm.
Thank you. That was a great presentation. In terms of prevention, you really can't change genetics, but you talked about exercise.
Yeah.
What I didn't hear a lot of is improving sleep quality. What is your thought on that?
Thank you for asking. There's no question that if you were to consider overall health, and I only mentioned, nutrition and exercise and those sorts of things, but yeah, sleep quality absolutely matters. anything that affects metabolism would matter a lot. And sleep patterns do. Now, sleep patterns can be affected by a lot of things. I mean, we could have given a talk about sleep apnea and other kinds of sleep problems. And certainly while there's ways to get help about that, it's something to pay attention to. If you're, running on caffeine all day and all night and then only getting 3 hours of sleep, that would be very bad for your health. I mean, that's something I know we've learned from when we're young, but when we're adults, we tend to think we're immune from hearing that. But thank you for bringing that up. There's no question that that matters in the overall health of a person. And really, you can kind of see by what we're trying to really affect in Alzheimer's is trying to help the overall health because we don't have a nice panacea cure. But thank you.
We have a Zoom question, if that's okay. How long does an individual usually live after receiving an Alzheimer's disease diagnosis?
It's highly variable. So for the question, for anybody that didn't hear that, how long does somebody typically live? A prognosis. So the good news is, and I don't know how I can couch this as good news. Typically, you're diagnosing this as somebody that is generally, as we saw the numbers, I mean, really, it's common in the 70s and 80s. So they didn't come into you thinking that they had 20 to 30 years left. One of the misnomers that has been out there is that you never die of Alzheimer's disease. Well, that's just not true, because when people start to shut down, they stop doing all kinds of things, physically being active, not sleeping, not drinking, not taking care of themselves, having accidents, and those are completely attributable to Alzheimer's disease. So I don't want to pretend it's not, but for the most part, when somebody gets diagnosed in their 80s, they have still a normal life expectancy. But saying that feels a little bit disingenuous because they're already sort of at their life expectancy. So it does shorten the time left. It shortens functional quality time. And when patients ask that question, that's where we try to go with it. Let's make every minute as high a quality as possible, because unfortunately it does shorten. Good question. Thank you.
Okay, coming at you over here.
Up here. You're good.
How important is it to identify the type of dementia a person has?
Thank you for asking. If someone has Alzheimer's or undifferentiated dementia, it's probably not very important to know some of the littlest details. But like I mentioned, the one at the chart, and I don't expect that you memorize the chart, but like there's that frontotemporal dementia. We do different things with that to try to help and treat. So at the big level, like the chart that I showed, it's important in that level. And any physician that deals with this a lot can help differentiate to that level. But now in the research, it's getting differentiated even more and more and more. Is this due to, tau proteins, or is this due to this or that? So at this point, it's not as important to know really finite levels, but that big level, the reason I brought them up is because that can differentiate some treatment. And that's important. I'm so sorry. Yeah. Yeah. Yeah, for those online, yeah. Yeah. So for those online, she's discussing a friend. I don't want to misquote the story, that's in an assisted living and is basically in a vegetative state right now. And oh, there you go. But not getting anything to keep it from progressing. There potentially are some things, but as you heard me sort of hedging, there's not a lot that can be done. If she's able to keep it all active, which I know is hard to do in a facility, and get a lot of social interaction, that's probably your best bet of like quality of life and things that would really help. And I wish there was more than that. It might be. Is it better than sitting alone at her house? Probably yes. Oh, well, then you go. Then it's not, because if you could have visited, then that would have been fun. And she would have liked that. Yeah. It's a tough decision that families make on when is the right time to get more help. And more help can be, of course, the combination of bringing people in or putting people in a different home. That's a crazy, complex, hard decision. Like it has so many multi-factors going on that I mean, I hope when I'm faced with those decisions in my family's life and for me, that people pay attention to the complexities, and there's not a one size fits all answer. I wish there was, but in a lot of times, somebody going into a home can be way better off because they do have more interaction and somebody to help and falls and things like that, because I also see all the people that fall at home, and that's a sad thing. And they're alone, and that's tough too. But I get it. Sometimes that has to be because people can't even afford to do anything else. So there's a lot of factors that go into end of life type of care, and that's where this gets to with Alzheimer's.
We just take one more question. One more. Sir?
Is there a certain ethnic group that's more prone to Alzheimer's or less prone to Alzheimer's worldwide?
Thank you for asking. And I want to answer this in two kind of ways. One of the real struggles we've faced in medicine for way too many years is trying to divide ethnicities and say that a person with this color skin or that color skin, or that's from Europe or that's from Africa, like that those have different physiological outcomes. When I cut someone open, we're the same inside. Now, having said that, are there some specific groups that have more troubles? Yes, but they also happen to line up with groups that are having trouble with things like diabetes and other metabolic issues. So groups that are having trouble with that are really struggling more with this. And I totally appreciate your question, but it's really hard. We're trying really hard to try to get medical students out of trying to differentiate everybody that way, because the research shows us, like if you put the person that you said, oh, well, this category of person is for sure going to have problems. If you put them in the environment of the other person growing up, they don't have it. So a lot of times it's environmental, and it's a lot of things that we don't understand. It could be nutritional, it can be, opportunity and those sorts of things. But to answer your question, there's not a lot of great data, and I can sit here and quote all the groups that struggle with diabetes, but that's the one correlation that we do see, and it happens to be ones that are very poverty-stricken, particularly in the U.S. Thank you.
There's one last question on Zoom, if you're
Okay,
okay with that.
sure.
Okay, and then we'll wrap up. Is whether or not there's a link between juvenile drug use and mental health issues with the possibility of developing Alzheimer's disease later in life?
Really good question, and the answer is sort of, I know my staff hates it when I say this. The answer is it depends. It depends on what drug use. If they did something that literally, I'll say fried the brain, because we all remember commercials from the 80s. I don't know, when they cooked an egg and said, this is your brain on drugs, but so it still maybe works for me. Somebody overtaught that to me. But if you hurt your brain, much like having traumatic brain injury or being knocked out a whole bunch, certainly that can affect your brain later in life. But we don't have a cause and effect of somebody, say, just being a drug addict and that then correlating to them being an Alzheimer's patient later on if they were able to clean up in the middle of that. So the answer is sort of yes or no, but thank you all. Appreciate the time.
Thank you so much,
Thanks.
everybody. Thank you, Dr. Embley.
Thank you. That's fun.
Can I take
Yeah,
your mic?
7 o'clock. Look at that.
For sure. You timed it so well. May I?